All right, everybody, we're going to get started here. This is Carol from the Society of Thoracic Surgeons. This is the Adult Cardiac Surgery Database monthly webinar for October 5th. Hank was baking this weekend. We were making Oli Bolin, and he got in the path of the powdered sugar, which he didn't complain too much about, but he definitely got it, and it was super cute. And Leanne just put the call-in number in the chat box there. Okay, so on the call with me today from STS, we have Leanne Jones, Sydney Clinton, and Melinda. From Iqvia, we have Joe Brower, and we have Nancy Honeycutt with us. I hope that everybody who was affected by the hurricanes is safe and that your families are safe. I'm sorry for everything that you've gone through, and if you need anything, please reach out to us at STS and try to do our best to help you through these times. We did get a couple requests. I got 1 or 2 requests about harvest extensions due to the hurricane. Right now, we cannot, we're not offering a harvest extension. So please try to get your cases in through September 30th with your 30-day follow-up. If anything changes, we'll be sure to let you know via email and on the upcoming webinars. Our agenda for today is important dates, STS updates, Iqvia updates. Melinda has a great education planned on coding of post-op reoperations, and then we'll do Q&A. Our dates were at October 5th. This is our monthly webinar, and then October 26th through the 28th will be in Rhode Island for AQO. Adult cardiac will be on October 27th. I hope that we'll see you there. Right now, we have almost 200 people registered for in-person with I believe it's like 140 that are for adult cardiac, somewhere over 100 for adult cardiac. So it'll be a nice group, and I'm looking forward to seeing everybody who's able to make it. On November 16th is our user group call. November 18th, Harvest 4 closes. I can't believe we're talking about November already. November 4th, Harvest 4 closes. That's OR dates through September 30th. So those impacted by the hurricane, you have about 6 weeks to hopefully, I'm certain that things take longer than that to get settled, but hopefully that'll give you enough time to get your cases in. December 7th is our next monthly webinar. And then our user group call in December is on the 21st. Harvest close, just the same screenshot. We are expecting this data back on Harvest 3, which is the star rating. We're expecting that back. It probably will be available. I think it's back from DCRI now. Iqvia is processing it to get it uploaded. It likely will not be available on the platform until after the week after AQO, but we'll keep you updated on that should things change. October training manual is posted. Registration for AQO. We're going to talk quickly about that next. October 27th is the date for adults. It'll be in Providence, Rhode Island. Early bird closed August 26th. So right now we're at the standard rates. In person, $750 for 1 track, $1,300 for 2 tracks. The multi-day, which is all 3 days, is $1,750, and the virtual pass is $400. A reminder that the virtual pass does not have any live streaming, so you'll have access to pre-recorded content, the on-demand content prior to AQO. I think the week prior to AQO, and then the recorded in-person sessions will be available to those who purchased the virtual pass and who attended in person in mid-November. I really hope if you are able to join us in person that you are able to join us. I think we guaranteed our rooms through October. I want to say it was 16th. So if you haven't booked your room yet, what's that? 18th. Oh, October 18th. Thanks, Leanne. That's why you're like my other half of my brain. October 18th. If you haven't booked your room yet, you want to do it before that date. Preliminary topics. We've gone over these before: the aorta, AVR, mitral valve, CABG, and anastomosis, bad ECMO, and PELAs. And then a really interesting presentation on databases used in value-based care. And you could see governmental. We'll have a talk from Dr. Keith Horvath regarding how value-based care is using databases to to come up with reimbursement rates, the TVT registry update from Dr. Joe Bavaria, and then cath chemo section. We're going green this year, so if you are attending in person, please print out any material and bring it with you, or have your tablet or your tablet or laptop with you if you're going to take notes. I suggest just printing out maybe the data collection form or something like that, and our agenda will be online. And now I'll hand it over to Joe for the Iqvia update, and I hope everybody is listening, because these are some exciting updates from Iqvia for this last release. So Joe, it's all yours.
Great, thank you very much. Good afternoon, everyone. As Carol said, we do have some good updates for you. As of this past weekend on October 3rd, we did add some additional variables to the non-analyzed participant dashboard report. So take a look under the sections listed there: post-operative events, risk factors, pre-operative cardiac status, coronary bypass, pre-operative medications, and discharge mortality, to see those variables in that report whenever you want, as of the 3rd.
Yes, I'm very excited about these updates. There were many that were added, so please check it out, and we will have another round of updates coming out for the other sections.
Yep. Also, the drop-down selections for your predefined date ranges now align with the harvest periods. Previously, they had been starting at the first of the year until the end of a quarter. Now they align exactly with the harvests. You can still always use the manual date range. That hasn't changed, so you can still type in a date range of your choosing. Just if you are using that drop down, it should be a little bit more useful for you now. And some fixes. I know many of you had reported that you were seeing, when you export your reports, that you had columns being cut off or pushed onto a second page, or that data at the bottom of the page was being cut off. Those two issues should now be resolved. So if you have reports that you printed previously that did have any of those issues, try exporting those again, and you should no longer experience that. And I think that's all we had. Yep. Just our usual reminders. If you did have tickets or anything that you wanted to reach out to us about, please feel free to do so. And we will be reviewing anything you have reported for upcoming releases.
Wonderful. Thank you, Joe. Thank you so much.
My pleasure.
There's two questions in the chat box, or in the Q&A I'm going to go to, and please enter your question. I'm going to shut the chat box down now, so please enter your questions using the Q&A function. If I can get to it. Oh, hi, Hank. Nobody. Okay. The questions are, is there a release date for Harvest 3? I believe it's going to be released probably the first week in November. That's what's planned. First week in November, that's what's planned right now. We'll let you know as we get closer to that date. I recently registered for in-person attendance. How do I give proof of vaccination? This question is from Beth. I believe that on the STS website, let's see if we can pull it up here. On the STS website, under a third party, that's what I thought. I just didn't want to misspeak, but a third party SMS texting based service will manage the collection of vaccine documentation. So they'll be reaching out to you by SMS, by texting, to verify that. And then see, how do we access the AQ webinars via the virtual means? We'll send you information for that once the platform is available. And then is the virtual attendance good, or all 3 days, or just the adult? It's for all 3 days. So virtual attendance would be for all 3 days. Okay. And now I'm going to hand it over to Melinda.
Thanks,
Take it
Carol.
away. You're welcome.
So today we're going to talk about coding of post-op reoperations. I get a lot of questions about this, so I thought it would be a good topic to go over. So when we look at the reoperations that we can code from. We have re-op for bleeding, we have re-op for valve dysfunction, unplanned coronary artery intervention, aortic re-intervention, re-op for other cardiac reasons, and then we also had return for non-cardiac reasons, and then we've got that open chest with planned delayed sternal closure. So there's a lot of choices, and so we're going to try to focus today on choosing the best choice given a scenario. The ones in red here that you see highlighted in red, these are the reoperations that go into the risk-adjusted surgical reoperation metric for the isolated cab. So you'll notice that that's the re-op for bleeding, the re-op for valve dysfunction, the unplanned coronary artery intervention, the aortic re-intervention, and the re-op for other cardiac reasons. So those are the components of that risk-adjusted surgical re-exploration metric for isolated cab. I get that question a lot too. Next slide. So we're going to just briefly go through each one of these definitions, and then we're going to have some scenarios. So the first one is sequence 6755. This is the post-op re-op bleeding tamponade. So I kind of highlighted in here patients who are re-explored for bleeding or suspected bleeding. Okay, so that's the key. If there is a suspicion that the patient's going south, it might be bleeding, we're going to take him back, and we get in there and we find bleeding, that's a re-op for bleed. Okay, so when you're reading these op notes or the intent of why they're going back to surgery, if you see the terms, you know, suspected bleeding, suspected tamponade, investigate why you know, the chest tubes are draining so much or whatever, those are kind of keys to re-op bleed. Now, and when we break this down, we have acute, which is within 24 hours of the exit time. We have late, which is more than 24 hours of the exit time. And then if it's exactly at 24 hours, we code that as acute. So the next slide. Okay. Sequence 6765 is for post-op re-op for valvular dysfunction. Okay, so the key here is this: it's a return to the operating room for prosthetic or native valve dysfunction. Okay, so this can include a surgical procedure or a transcatheter procedure on a prosthetic or a native valve that has dysfunction. And all of these are re-ops, and we're not talking about any planned re-ops here, okay? We're talking about complications. So the next slide. Okay, so 6771 is post-op unplanned coronary artery intervention. So the key here is that these people require an intervention to a native coronary artery or coronary artery bypass graft. So these are patients that go back, it's unplanned, they have some sort of intervention on the coronary artery. The coronary artery is requiring some sort of revascularization. It may have a clot in it or a stenosis in it or this or that, but there's some reason they've got to intervene on that coronary artery or the graft. And if you go back to the cath lab and they attempt a PCI, even if it's not successful, then we code those as PCI. So that attempted PCI would be coded in this particular sequence if that occurred. So this is an intervention on the coronary artery or the bypass graft. Next slide. Okay, so sequence 6774 is post-op aortic reintervention. Okay, so this is an unplanned operative aortic intervention. And this can include patients that are in an OR suite or an equivalent OR suite, such as the bedside or some other hybrid operating room or things of that nature. So this is an aortic intervention. And it can be on a native part of the aorta, or it could be on a part of the aorta that you've already operated on. But the key here is it's an aorta intervention. All right, then we have sequence 6778, which is re-op for other cardiac reasons. Now, this one I think can be challenging for people because it's kind of a catch-all for any other kind of cardiac thing that we haven't already talked about. So the key here is it's cardiac reason. So this can be patients that maybe have a cardiac arrest and they go back to the OR and they're investigating why the patient arrested and they find some other cardiac reason that they have to fix. This can include patients that are at the bedside or at a hybrid OR or a regular OR. The return to the OR for removal of Impellas, balloon pumps, or ECMOs are not considered reoperations because that's expectation. It's not a complication. You put ECMO in, you have to take it out. No. And the same for impeller or balloon pump. We do have one caveat here. Capture the initiation of post-op ECMO as other cardiac re-op. So regardless of where you put it in. So if you get ECMO post-op, you're going to fill out the ECMO sequence 3766 through 3780. And you're also going to code this as sequence 6778, a re-op for other cardiac, for any ECMO placed post-op. So the next slide is return to the OR for another non-cardiac reason. So these are non-cardiacs. These could be wound issues. These could be abdominal issues. These could be hip issues, whatever, any kind of non-cardiac procedures. You're not working on the heart. You're not working on the structures, the cardiac structures. Again, this is not these events, when you code return to the OR for other non-cardiac reason, those events are not captured in the reoperative measure for the composite score. So they're not in there. So don't worry if you code this. It's not going to affect any metric. This sequence does not include tracheostomies. All tracheostomies, regardless of where they're performed, are captured in sequence 6838. This also does not include procedures performed outside the operating room, such like GI labs or, places other than the OR. And sometimes certain sites will have operations that are done in the OR where other sites don't do those procedures in the OR. For example, some sites might have a peg tube put in the OR and other sites have that put in a GI lab. If you go to the OR for a non-cardiac reason, you're utilizing OR resources, then you code this as a return to the OR for other non-cardiac reason. Okay. All right. Okay, now we've got one last one, and I threw this in because I get a lot of questions about this. This is sequence 6785. This is the post-op open chest with planned delayed sternal closure. So the key here is you want to indicate whether the chest was left open after the index surgical procedure with planned delayed sternal closure. Now, sometimes people get hung up on that planned delayed sternal closure. Basically, if your patient leaves the OR with this chest open, you have to close it. So basically what this sequence is asking you is, did the patient after the index procedure leave the OR with an open chest? Yes or no? That's what it's asking. And if that chest was left open, of course, there's going to be a planned sternal closure at some point when the patient's stable enough to do that, because we can't leave the chest open. So if, a little caveat here, if the patient's chest was left open and the patient dies before it's closed, you're going to still code this because the patient left the OR with an open chest. All right. Okie dokie. So we have some polling questions. I think we have about 10 of these. And we're going to go through and see how you guys do with coding of reoperations. Now, these are complications. These are not planned procedures when I'm reading these questions, okay? If a patient goes to the cath lab after CABG to have a permanent pacemaker placed for post-op complete heart block, is this coded as a return to OR for other cardiac reasons? The answers are yes, no, or unsure. All right, that's pretty good. These are pretty good answers.
Yeah, we'll let it go just for a few more seconds here. We got good response rate too.
Mm-hmm.
Okay, I'm gonna end it and share the results.
Okay, so we've got like an 80-20 split here, and 80% saying no, and the answer is no. So we'll break this down. So this patient went to the cath lab to have a pacemaker put in. Okay, so they didn't return to the OR for one thing. The second thing is this pacemaker was put in for complete heart block. So you're going to code this particular situation in 6901, which says indicate if the patient developed a new dysrhythmia requiring insertion of a permanent device. Do not code in the reoperation section, even if performed in the OR. So for this particular scenario, it wasn't in the OR. The patient had a permanent pacemaker put in. It was for a complete heart block, which was a dysrhythmia. So this is actually coded in 6901.
Melinda, I have a question. Thank you. I have a question on this one. Would you ever code permanent pacemaker after an index operation as a return to OR for other cardiac reasons?
I wouldn't think so. I mean, because generally speaking, a permanent pacemaker is put in for some reason.
Mm-hmm.
Would probably be some dysrhythmia, which would,
Okay.
and those pacemakers go in 6901. I mean, unless there's some unusual circumstance out there, I would think not.
Okay, thank you. Next question.
Is a post-op diagnostic cath coded as a reop for unplanned coronary artery intervention? Yes, no, or unsure?
Ooh. They're doing good.
Mm-hmm. Yep,
Either real good or real bad.
they're doing real good. I put the easy questions first.
Oh boy. Okay, I'm gonna end it here.
Okay, so 92% said no, and the answer is no. Okay, so this was a cath, and it was a diagnostic cath. Okay, so there was no intervention done on the coronary artery. So that's the key. So if you just go and you have a diagnostic cath done and you don't do any intervention, there's really no place to code this. And I get this question quite a bit. So there's absolutely no place to code this because you didn't do any intervention on the coronary artery.
Okay.
All right. Question number 3. All right, let's see. Post-op sternal wound incision and drainage and placement of vac dressing. Is this coded as a reop cardiac or a reop non-cardiac?
This one was pretty clear to me. I'm surprised to see the numbers right now.
I get this question a lot.
Interesting.
Okay. Good participation.
Okay, let's end it.
Okay, so we got like about a 20-80 split, with re-op being about 77% of the people and re-op non-cardiac. And the answer is re-op non-cardiac. Okay, so the key here is that this is for a sternal wound. It's a wound issue. There's not a cardiac issue here. We're not going in and we're not messing with any of the cardiac structures. We're simply taking care of that sternal wound. So this is a re-op non-cardiac. Question number 4. Post-op, the patient with cardiogenic shock is taken to the OR for replacement of a right axillary Impella 5.5 device. Is this coded as a re-op for other cardiac? Yes, no, or unsure?
You're getting tricky, Melinda. You're getting tricky. Okay.
Yeah, we kind of a split here. We've got about a 60-40 split here, with 61% of the people saying yes, this is a re-op cardiac, and yes, this is a re-op cardiac. This is a patient that has cardiogenic shock, so there's clearly something going on. And they take them to the OR and they put this Impella in. So this is a re-op for other cardiac. Next slide. Here we go. Patient had an MVR. Post-op developed severe AR. Patient returns to the OR for AVR. How is this coded? Re-op other cardiac, re-op valve dysfunction, or unsure? Right about 75-25 here.
Okay, I'm gonna end the poll now.
All right, so we've got 75% of the people saying that this is a re-op for valve dysfunction, and that is the correct answer. So when you look at this, the patient had an MVR. Post-op, they got severe AR, and they had to go back to the OR for an aortic valve replacement. So this is a re-op for valve dysfunction. And if you remember, in the definition for the re-op for valve dysfunction, it states that it can be prosthetic or native valve dysfunction. So this is new native valve dysfunction. It was probably most likely caused by something during the MVR. Could or could not have been. But anyway, this would be coded as a re-op valve dysfunction. Question number 6. Patient had an AVR, went to the OR post-op for a pericardial window to treat his pericardial effusion. How do you code this? Is this a re-op bleed, a re-op other cardiac, a re-op non-cardiac, or are you unsure about how to code this?
I think switching the slide accidentally screwed up people's
No, this one's a tricky one. This is always a tricky one. I was just curious to see the breakdown.
Okay, I'm gonna end it.
And it looks like this one's like all over the place. So the majority of the people, 46% of you guys said that this was a re-op other cardiac, and that is the correct answer. And I recently put something in the training manual about this because I get a lot of questions about this. And I think in the past, this may have been, there may have been some education in the distant past that said this was a re-op bleed, but most recently, and since I've been doing this position, we've clarified that with the surgeons, and this is actually a re-op other cardiac. It involves the pericardium. It's secondary to the cardiac operation, but it's not necessarily a re-op for bleed. It's a re-op for other cardiac. And I recently put that in the training manual to help people better understand where these pericardial windows post-op belong. Question number 7. Okay, so this patient had a CABG. He has significant chest tube output overnight, and despite transfusion and medical management, they take him to the OR. They're going to wash out and evacuate the chest hematoma. How is this coded? Is this a re-op bleed, a re-op other cardiac, or unsure? Oh, they're doing good. Doing real good.
Real good. Okay, I'm gonna end it.
Okay, so 98% of you guys said that this was a re-op bleed, and that is the answer. So if you break this down, this patient had a lot of chest tube. He got transfusions. They were medically managing him. They took him to the OR because they wanted to see what was going on, and they found a hematoma in there, which we all know is a collection of old blood. So this was a re-op for bleed. And we see a lot of these. And typically it's like this a lot. So this is a really good example of a re-op bleed. Thank you for whoever sent that question in. All right, question number 8. Surgery on 7/14. Did not have a planned delayed closure pre-op. Rather, the heart was swollen and chest closure was not possible. Would this be coded as an open chest with planned delayed sternal closure? Yes, no, or unsure? All right. It's like they're pretty good with this one. This one can be tricky.
Okay, I'm gonna end the poll now.
Okay, we've got 88% saying yes, and yes, this is a delayed sternal closure. Okay, so again, don't let that planned verbiage confuse you. The patient left the OR with an open chest. And after all, you have to go back to close it. So if the patient leaves the OR from the index procedure, that's key there too. The index procedure, open chest, then you code delayed sternal closure. Because after all, you do have to close it at some point. Okay. All right. Oh, well, let me mention something else about that I just thought about. And when you're answering this question, it's accounting for that return to the OR to close the chest. So when you finally go back to the OR to close that chest, it's accounted for in this sequence here, this delayed sternal closure. So you wouldn't be coding another reoperation. It's accounted for in this particular sequence. Okay. Number 9. Cabbage yesterday. Retained hemothorax on chest x-ray today. Taken to OR, hemothorax evacuated. Arterial bleeding noted in area of the LAD. A suture was used to repair this area. How is this coded? So this is kind of a tricky one. Is this a reop bleed? Is this a reop unplanned coronary intervention? Is this a reop bleed and an unplanned coronary intervention? Or are you not sure about how to code this? This is kind of a tricky one. But I get a lot of questions like this, as I suspected. Wow, we got answers in all 4 answers. 59% of the people saying it's a reop bleed, closely followed by 33% of the people saying it's a reop bleed and an unplanned coronary intervention. So what is the answer here? And the answer is, this is a reop bleed. Okay, so we're going to break this down a little bit. So clearly the patient had a bleed because there's a retained hemothorax on the chest x-ray. And so they went in to evacuate that hemothorax. They noted that there was some bleeding in the area of the LAD, so they put a suture there. So the bleeding site was the area of the LAD. The LAD itself did not need a coronary intervention. It was the source of the bleed, but it was not in any need of any revascularization, which is the intent of unplanned coronary intervention. The intent is you're going to revascularize something, intervene on something that needs to be revascularized. So for this particular situation, this is just a reop bleed. And the LAD was the source of the bleed. And that was fixed with a suture. Okay, question number 10. I think we actually have 2 more. Cabbage with severe RV dysfunction after coming off bypass. Patient is closed and decision is made to take directly to the cath lab. A stent was placed in the RCA. Is this coded as post-op unplanned coronary artery intervention? Yes, no, or unsure?
This is a good question, Melinda.
I know it's a good question. It is a good question. And I'm happy to see that. Yeah. We've got 73% of the people saying that this is an unplanned coronary artery intervention, 25% saying it's not.
Okay, let's end it here.
Okay, and so let's see what the answer is. The answer is yes, this is an unplanned post-op coronary intervention. So we're going to break this down a little bit. So historically speaking, this has always been coded as an unplanned coronary intervention. But I think that some people are getting confused by the plan, and because they say that, oh, well, this patient was still in the OR when they decided to go to the cath lab. Well, in this particular situation, the patient was off bypass. They closed the patient and they took the patient directly to the cath lab. So this patient was decompensating. Bypass was off. They closed the chest and then they went directly to the cath lab, and they stented the native RCA. This is clear. It's in this particular situation, this is a post-op unplanned coronary artery intervention. It's not like the patient was in the OR and the surgeon decided, oh, during surgery, he's working, he wants to attach a graft to the RCA, but he can't because he just doesn't have the ability to do it. And he says, oh, well, after surgery, we'll go and put a stent in the cath lab. That's clearly planned. This was not planned. This patient was decompensating. His bypass was off. His chest was closed, and he left the operating room, went to the cath lab, and had a stent put in his RCA. So this is an unplanned coronary artery intervention. Okay, last one. This one's going to be tricky. Patient presents with a type B dissection, and a T-bar was done by CT surgeon and vascular. Oh, you're giving the answer, Carol.
Yeah, so I didn't mean to click on that. I accidentally, I don't have this. I didn't get this question in the polling questions.
You did. I saw the answer. I thought. Oh, you didn't get in the polling questions?
Or I didn't get it in the polling questions.
Oh, okay. So we'll just go over it then. Patient presents with a type B dissection, and the T-bar was done by CT surgeon and vascular. Post-op develops retrograde extension and returns to surgery for the open ascending and arch repair. How do I code this? So the answers are: open ascending and arch repair is the index procedure. T-bar is a prior CV intervention. That's A. B, re-op aorta for open ascending and arch procedure. Or C, I'm going to complete a data collection form for both the T-bar and the open ascending and arch procedure. So this one's got a lot of detail to it, and we don't have a poll, so I'll break it down on the next slide. So the answer to this is a re-op aorta for open ascending and arch procedure. Okay, and so let's just break it down, because I get a lot of questions about this. So why is answer A not right? Because T-bars done by CT surgeons and vascular are required entry. So they're index procedures. So answer A would definitely not be right, because your T-bar is your index procedure in this particular situation. Answer C is not right, because we only have one data collection form per episode of care. So we don't complete a data collection form for each procedure that's done. We only have one per index procedure. So answer B has to be, and is the correct answer, because this is a re-op on the aorta. So you had a T-bar, you've got retrograde extension post-op that develops, and the patient has to go back and have an open ascending and arch repair. So this is a re-op for the aorta. That's how you would code that. I think that's all I have. Yeah.
Yep, that was all of them, and now we can go to questions, and some good ones coming in.
I hope I can answer them.
Yeah, I think, be interesting to hear the discussion. The first one is for the explant valve field. So this is not related to the presentation. But we'll go over it. For the explanted valve field, if you have limited information on the explant, like date and description of model, but not model number, can you use other FDA device? For example, I have the date and mechanical St. Jude aortic device explanted, but not the model of the St. Jude valve.
I'm just reading it again. I think I would just leave it blank. I mean, because I think that's the best. I would leave it blank.
Yeah.
Because I think if you chose other FDA approved device, you might be misrepresenting. I don't know. It just seems more logical to leave it blank.
Okay. If ECMO is placed during the same OR visit as a cabbage, still coded as other cardiac reason, question mark?
No, ECMO is only coded as a, when you have ECMO placed post-op. And that is coded as other cardiac surgery, re-op for other cardiac reasons.
Yeah, let's pull up the data collection form here.
Because you're going to code, if you have an ECMO that's done during a cabbage, you're going to code that in sequence 3778 or something like that. 3778.
I'm getting there. Yeah, hold on. Sorry, I'm not gonna keep scrolling.
There it is. So if you have ECMO placed during the OR visit, you're going to capture it under the mechanical cardiac assist devices. If you have ECMO placed post-op, then you're going to code that as a re-op for other cardiac reasons, regardless of where it's placed, whether it be at the bedside or in the OR. That was,
and you'll also still capture it under mechanical cardiac assist device.
yes, you capture it there too, and as a re-op other cardiac. That was a surgeon leadership directive that came out. It was like, I don't know, what's that, year and a half ago or something.
Yeah, and just to say it another way, Melinda, I think what you were getting at with the demonstration of timing of the patient being off pump and going south after being off pump, and let's get back to that.
It was number,
Was it 1?
no, the re-op for, which one are you talking about?
Oh, maybe it was. What was the question you had that
That was for the re-op for native coronary artery dysfunction reintervention.
so I think what you're saying here is that after coming off CPB is when you would consider that. So let's say that, what do you think about this, that patient comes off a CPB, they start deteriorating before OR exit, and they end up putting the patient on ECMO? Is it an unplanned is it an unplanned event?
I think that surgeons would have to decide that, because we've not had those discussions at all.
Okay. But for this question, where the ECMO was placed during the same OR visit as the cab, and assuming that they consented to this, right, Melinda?
If the are you asking me about the question if ECMO was placed during the OR visit, same OR visit as the cabbage, is it coded as other cardiac? Is that what you're asking me?
Yeah, it's not coded as other cardiac because it was done at the same time as the cabbage.
Correct. For now.
Yeah. How do you code post-op pericardial effusion going back to OR for pericardial window? Oh, we had that question.
That's the re-op cardiac.
Yeah, and we have a couple other questions that are going to go along with that. We'll get to in a second. Would 6780 be where we capture re-op related to vein harvest site?
What's 6780?
Oops, 1 second, let's pull it up. return to OR for other non-cardiac reasons.
Yes, if you had to go to the OR related to a vein harvest site, that's where you capture.
Okay, and Kim's asking, what about a patient who goes back to the OR to have a lead and device extraction, ICD, due to positive blood cultures?
Lead. It's probably another cardiac, but they're going in there and removing an ICD and taking out leads. I would say other cardiac. Yeah. If it's done in the OR.
The acute debridement in the OR after transferred to LTAC, do I capture this? No.
Okay, wait a minute. Let me break this one down. So first of all, the patient was transferred to LTAC. So the patient was discharged to LTAC. LTAC is an acute, it's not an acute care hospital. So so this patient had a debridement in the OR after the patient was discharged from the hospital. So no, you don't capture that debridement at all because the patient was already discharged, unless the patient's readmitted. I guess I don't have enough information to know to answer that question thoroughly. But you can send it into the FAQ if you have more information about that.
Thank you. Post-operative ECMO placed for pulmonary insufficiency, VV ECMO, not AV ECMO. Is this still considered other cardiac reop? VV ECMO is not normally placed for cardiac support of any kind.
Per the surgeon leadership, it's captured as a reop other cardiac.
Thank you.
We can ask, I can break it down a little bit for them, but right now, any ECMO placed post-op is coded that way.
Okay. Natalia is asking, Melinda, just to clarify, you want coding return to OR for other non-cardiac reasons if the patient actually goes to the OR, regardless of the procedure, as in a peg plate, as in peg placement.
Yes, unless it's a tracheostomy, which is captured in its own place, and unless it's a pacemaker, it's captured in its own place, which is 6901. But if you're going to the OR for a peg and you're using OR resources to do that, then yes, you code that. But again, a reop for non-cardiac does not affect any of your metrics. And like I said, some hospitals will take patients to the OR for some procedures where other hospitals will not take them to the OR. So.
Okay, and then there's a few questions, a few questions on question number 3. Oh, I skipped over Mary, sorry. Is there anywhere to code post-op cardioversions?
That usually goes in the AFib category, if it's for AFib, which is 6945.
Thank you. All right, couple questions on number 3. This was the question about the wound vac placement. IND placement of vac.
It was in the OR.
What's that?
It was in the OR. I guess I didn't say that, but
it's okay. Then you took away all the questions. If the Impella 5.5 was placed in the cath lab instead of the OR, is that still a reoperation other cardiac?
No, because it was in the cath lab, not in the OR.
Okay.
But unfortunately, you can't really put those Impella 5.5s in the cath lab, from what I understand. They require a surgical procedure.
Because they're so big.
And that patient was in, that patient required to go to the OR because of the insertion of that device, and the patient was in shock.
Okay. Impella 5.5 post-op, should this also be quoted under cardiac support device as a post-op catheter-based device?
Yes, this would be coded as the reop. And would also be coded in the temporary assist device section. All Impellas, it doesn't matter what type of Impella it is, all Impellas are coded as temporary assist devices. They are not coded as VADs. All Impellas are temporary assist devices. I get that question all the time. So I like to take the opportunity to reiterate that. So right there, all
Yes,
Impellas.
basis, right here.
Yes, temporary assist device used.
Okay, thank you. Sometimes we have an ICD placed post-op for low EF without any new rhythm disturbance. Would this still be coded under 6901, or would it be coded under reop for other cardiac because it was not for a dysrhythmia?
Well, we'd have to look at that one closer. Was there any pre-planning for this? Was it done in the OR? Was it done in the cath lab? I mean, that one's kind of needs some more.
Do they place it prophylactically?
Well,
or-
yeah, sometimes they do that. It depends on how it's documented. I mean,
Yeah, I think
you
you would need
if
more information, right? If it's
the EP doc saw the patient pre-op and said, hey, you know, he might need an ICD post-op if his EF doesn't come up or something. I mean, it just all depends. Because we don't code planned procedures. So I mean, like if there's a plan, okay, I get this one all the time. So a patient comes in with a cardiac arrest. They go to surgery. Well, prior to surgery, the EP doc's already seen the patient. They're like, hey, you know, this guy may need an ICD post-op as secondary prevention, you know, because he had a cardiac arrest. And so before and after surgery, the patient still has a low EF, and EP doc comes back and he says, you know what? I'm going to put this ICD in before he goes home because his EF's so low. He's already had one cardiac arrest, and they put it in. But in that situation, we don't really code that because it was planned. The EP doc saw him pre-op, said, hey, you might have to have this done. It was an ICD for a secondary prevention from arrest. So you got to kind of look at the situation.
okay.
Which is why I ask so many questions. When you guys send me questions, I always ask lots of questions for those of you.
Yeah, I'm gonna add, this is this couple on the pericardial effusion question. And let's see if I can find that.
I think they're talking about the pericardial window.
Yeah.
And the surgeon leadership basically said that that's a re-op other cardiacs, not re-op for bleed in the fashion of re-op bleed that they want to capture it as.
Thank you.
So that's why we're going to capture it as a re-op other cardiac.
And what if it's documented? What if it's documented as blood? It's still considered a pericardial effusion. Tamponades. Do you want to talk about tamponades? How are tamponades coded?
Well, yeah, it depends. I mean, sometimes you have tamponade and you go to the OR and you've got a big bleed in your chest, and that's causing the tamponade. So that's a re-op for bleed. Sometimes you have tamponade or pre-tamponade or early tamponade, and the patient goes and has a pericardial window put in, and that's a re-op for the cardiac per surgeon leadership. Sometimes you have tamponade and they just do a paracentesis at the bedside, and that's coded down under let's see, this is that. I think it's tamponade. It's further down on this data collection sheet.
Tamponades right here, 6755, but which one were you looking for?
So That's tamponade reop bleed. That's when you go to in, you're bleeding, and the bleed's causing a tamponade. That's a reop bleed. Then you've got pericardial windows that can cause tamponade or pre-tamponade or early tamponade. That's coded as sequence 6778. That's reop cardiac. Then slide down further. Then you have tamponade that's treated with a paracentesis. And that is coded as, where is it at? I don't get this. There it is, right there.
Pericardiocentesis.
6933.
Yeah, it's there's a lot going on here.
There's a lot going on here. Yeah. So.
And then Kim's just, I guess we're at time. It's over 5 minutes late and we have 12 questions. Kim, Melinda, if you wanted to look at Kim's question, and I don't know if there's anything in the training manual that we can adjust.
I'm not.
And then I just want to check for Katie's question. So for question 10, if the decision is made after chest closed, then it would not be coded as a planned PCI post-surgery.
Whose question are you looking at? I'm sorry.
It's okay.
Oh, right, way down here. Okay. The decision is made after the chest is closed, then it would not be. Okay. Okay. I don't understand what she's asking me. So
If the decision was made after the chest closed, then it would not be coded as a planned PCI post-surgery.
well, it's not planned anyway. It's unplanned. It's an unplanned coronary intervention. So
Okay.
So that's why I'm confused. So they had to close the chest in this case to take the patient to the cath lab. Very infrequently do they, I don't think I've ever seen it done, but run the patient to the cath lab, leave the chest open and run them back to close them. So they had to close the chest. The key here is that they made this patient was off bypass. So technically the procedure was completed. And when I took this scenario to surgeon leadership, because I knew historically we've always coded this as an unplanned coronary intervention, but I was getting questions about it. So I took this to surgeon leadership, and every one of them that saw this question, and there were 8 of them, said this is to be coded as an unplanned coronary artery intervention. So, and I know that sometimes this is kind of hard.
Maybe we need to do a whole nother.
Yeah, I put this in the training manual
Yeah.
just this month because I wanted people to be aware of that, even though I knew it. And I think a lot of people knew it already because we could see by the responses that a lot of people knew it already. So this is just part of the education. It's just making sure that we're all understanding things like they should be understood. Hopefully, this was helpful, but maybe it was more confusing.
There's still some more questions. Do you have time do about 10 more minutes, Melinda?
Sure.
Okay, we'll end at Ala's question. I'm looking at the training manual incorrectly. Sequence 2140 do not include ECMO, Impella, or IABP insertions.
2140, what is that?
Let's see.
I don't think that has anything to do
That sounds pre-op. Other cardiac procedure except AFib. Well, this is your planned procedures.
Yes, correct. And we have a spot for ECMO, Impella, and VADS right there under mechanical assist ventricular assist devices.
I'm going to talk a little bit about this because you did a presentation on this a few months ago where we talked about the difference between this field, other cardiac procedure except AFib, and we talked about the unplanned unplanned return to OR for other cardiac procedure. They're two separate fields with separate definitions. This one is planned. It's on the consent form. This is what the patient's entering the operating room to have done. It does not include the Impellas, ECMOs, or balloon pumps. The Impella ECMO balloon pumps, if planned, consented for prior to surgery, they go up here in the mechanical assist device, ventricular assist device section. Post-operatively, if the patient has to have an Impella or an ECMO or a balloon pump placed, those are counted as return to OR for unplanned return to OR for other cardiac reasons. So two separate fields with two separate definitions. Okay, next question. When an artery cannot be bypassed and a decision is made to take the patient to cath lab for stent, is that planned or unplanned coronary intervention? And I think the answer to that is that it depends on the timing and when that decision was made.
Right. If they decide to put a stent in that artery intra-op during the index procedure, and they're like, okay, I can't bypass this, so 2 days from now we're going to go back and, it's a very controlled situation, we're going to go back and stent it, then yes, then we would not code that as sequence 6771 because it was planned, the patient it's a very different situation than when the patient's decompensating,
Right.
and is already off bypass. But if during the surgery, the surgeon says, "Oh, I can't bypass this. We're going to stent it." So different situation. But yeah, it wouldn't. There's no place to code it really.
Okay. Next question. I can take this one. On question 11, this would only be coded this way if the patient was still in hospital for the index procedure. Yeah, that's correct. If the patient came in and had a TEVAR, type B dissection and TEVAR done by CT surgery, and they get discharged home, and then a few days after discharge, they develop a retrograde extension. They had to be readmitted and have an open ascending arch. You would fill out a new data collection form for the second procedure, and you would capture the readmission on the first DCF. Next question. If a patient has CV surgery, then returns to the OR later for femoral repair by vascular surgeon due to injury during the initial procedure, how is this coded?
So CV surgery, femoral. This would be other non-cardiac re-op.
Yeah, re-op other non-cardiac. Like 11, if TAVR goes badly and turns into an open procedure, do you still keep the TAVR as index operation? Then the open procedure would be a re-op. And this is
No, Stephanie, that I have a whole slide presentation for how you code that, and we presented that a couple months ago. Please send me a question in the FAQ mailbox so I can get that slide presentation to you. It's a completely different concept because TAVRs are optional to enter into our database. And so when it comes to a case where you have a TAVR and a SAVR, the SAVR is the index procedure, not the TAVR, because those are optional. So please, if you want those slides, please send me a question in the mailbox and I'll be happy to get them to you.
okay. The Impellas or the Impella 5.5s, they do not get put on the red cap form. That is for valve devices.
What question you're
and VAD devices. Impella 5.5s are not considered VADs. They're considered temporary cardiac assist devices.
correct?
Does right thoracotomy for spontaneous pneumothorax count as first re-op?
So right thoracotomy. First,
It depends what was performed before.
yeah, I don't know. Michelle, you have to send me that question.
Um,
Okay, what's next?
Yeah, they're trying to reconcile, that's right, they are trying to reconcile question 10 with sequence 2606, but it's a totally different field. They're two separate fields.
Mhm.
My confusion on coding 10 is that the definition says if the decision was made prior to OR exit, then we code planned PCI.
That's why I have an update in the October training manual that was just put out, because like I said, I met with the surgeons, the leadership team, and it was very clear to them that the particular situation here that I presented to you is an unplanned coronary artery intervention. So it is in the training manual for you to review.
And Melinda, do you want to talk about if the PCI was planned before they closed the chest, if that would change anything?
It would. I mean, if they, well, and off bypass, that's another key. I mean, this patient came off bypass, had his chest closed, and he was still deteriorating. He was deteriorating. Okay. It's not a controlled situation. Something happened and they had to go fix this, whatever was going on. And what they found when they got to the cath lab, because I can only put so many words on this, on these slides, otherwise you can't do polling. But what they found in the cath lab is that there had been a clot dislodged into the native RCA. And so they had to, of course, open that up. If you have a patient and you're in the OR and the surgeon's actively performing the surgery and he can't bypass the RCA, he's like, I just can't get this done, you know, and I'm going to address this post-op. I'm going to do a PCI later or take him to the cath lab later. That's a completely different scenario. The surgery's still going on, it's still commencing. The patient's stable. It's a controlled situation. It's a completely different situation than this particular scenario that we're talking about.
Yeah, and I'm going to talk a little, thanks, Melinda. I'm going to talk a little bit. Katie sent some, the definition for 2606 with the intent clarification. And what 2606 is talking about, this planned post-procedure PCI, this field 2606 is referring to a procedure that is planned prior to the patient entering the operating room, right? It's planned that it was in the medical provider's notes, and at time of initial surgery, if the surgeon determines that a vessel is not bypassable and more suitable for PCI, then you can code it as yes. So it has to be within the time of surgery. Nothing for 2606 that we're talking about coming off bypass or anything like that. It's a totally different field.
Yeah.
Okay. All right, I think we're going to stop there. We've got 4 more. Want to take them? Grace, the slides will be posted on the webinar page on the STS webinar page. If you go to the sts.org registries, STS National Database, and then scroll down on this page, live webinars, view webinars, you'll find a copy, the past webinars, you'll find a copy of the slides and a recording.
I want to answer Jamie's question, and Peter's is the same one, basically.
Okay.
So per the training manual, the surgeon comes off bypass and closes the chest, but needs to reopen for bleeding. We do not capture this as a re-up bleed, even though it wasn't planned. Same for ECMO historically. Well, that's true. That's the way it is. So if you come off bypass and the surgeon has to reopen for bleeding or something of that nature, then his surgical procedure is not complete. He's reopening the patient. So, and that's the same concept for ECMO, even though Carol brought up a point earlier. I think that is the concept that we've historically always gone with. If you put ECMO in, or you put a VAD in, or you open the chest, fix bleed, all of that is within the operative setting. This situation in question number 10 that's caused such controversy is sort of like an exception to the rule, I would guess you would say. And I think we just have to take it for what it is. I mean, surgeons
Yeah,
were
I think
very,
I think it
Yeah.
gets a little, I think what is causing the blurriness is this stent is a totally different procedure. And the reason, whereas if they're going into, they close the patient up, patient starts bleeding, they reopen the patient, they never left the OR, so that initial procedure wasn't complete.
right. And
The
this,
stent is a totally different procedure.
yeah, they left the OR. They
Mhm.
went to the cath lab. There was a completely different crew of people taking care of the patient. I mean, so it's a completely different situation than reopening the chest during OR.
Okay. Katie says, thank you for the clarification. Linda says, thank you. ET sub. Oh,
I think we just answered that question.
okay. And then the last question is the list of index operations for the required cases on the sts.org website. If you go under STS National Database, Adult Cardiac, and Access Data Collection Resources, version 4.20. If you scroll down here under other additional resources, there's a case inclusion guide. And this Melinda and the core group put this together. It has all the required cases, things that are done in conjunction with other cases, and then the list of optional cases. Okay, so thanks everybody. Thank you so much, Melinda.
You're welcome. I hope I didn't
Okay,
confuse too many
amazing.
people.
No, I think it's very helpful. It's good to get clarification out there. So thanks, everybody. Thanks, my team at STS and Melinda and Joe for all your help. Hope everybody has a great day and stay safe and take care.